clinicians heading to make to establish treatment and to prevent fractures, and we still have doubts on when to do that and how to do that best. So it will be awesome for us to hear from an expert. Professor Nicholas Harvey is a professor of rheumatology and clinical epidemiology at the MRC Life Course Epidemiology Unit in the University of Southampton in the UK. He's the chair of the International Osteoporosis Foundation Committee of Scientific Advisors, a clinical trustee of the UK Society, Royal Osteoporosis Society, and vice chair of the Royal Osteoporosis Society Osteoporosis and Bone Research Academy. He leads an MRC program focused on the life course epidemiology of bone and joint disease, and has won several national and international prizes, such as the IOF Medal of Achievement and the UK National Osteoporosis Society Con Award. He's an investigator on more than £50 million grant funding and has published over 225 peer-reviewed papers, and serves on many national and international committees, including the American Society for Bone and Mineral Research Professional Practice Committee, the UK National Osteoporosis Guideline Group Advisory Committee, and the UK Biobank Imaging Working Group. As you can see from this extensive CV, who is really like summarized to a few sentences, Dr. Harvey is a great specialist in the topic that we're going to talk about, so I think we are all in for a great treat. Thank you, Dr. Harvey.
Thank you very much, Bruno, and fantastic to be working with you again for this seminar. So it's a great pleasure to be here, and let's get my slide to move forward. There we go. What I thought I would do is sort of take a reasonably high-level look at the latest thinking around the identification and assessment of patients at high fracture risk. And that will take around half an hour to 40 minutes, and then we'll have the opportunity to talk more about some of the sort of detailed clinical scenarios that might arise, and to talk through some of those nitty-gritty areas that might be helpful in day-to-day clinical practice. So what I thought I would do is very briefly say something about the impact and burden of osteoporotic fracture currently, and just look at the issues in osteoporosis in terms of the care gap in both primary and secondary prevention. Look particularly at approaches to the concept of very high fracture risk, and then screening, and looking a little bit about long-term treatment before concluding. So it's probably no surprise to this audience that osteoporosis-related fractures are a major public health issue, and that's because they're common, and because they're getting more common, and because they've got substantial associated morbidity together with impact on mortality. So in these data from Europe in our recent paper, we see that the disability associated with fragility fractures is pretty similar to that from chronic lung disease, lung cancer, not far off that of dementia. And if we look at the age distribution across various countries, you can see UK, US, China, Brazil, you can see that in coming decades, we expect this 80-plus age band to increase as a proportion. So populations are getting old, and we know that we see the same sort of effects across Europe, across European countries, in the IOF scope report published recently. But that impact on the population demographics, regardless of what's happening to age and sex-adjusted fracture rates, which in many high-income countries is now plateaued, but in many low and middle-income countries is increasing anyway, we're going to see an increasing burden of osteoporotic fracture. And if we look at the number of individuals at high fracture probability, so this is the number of individuals worldwide who have a probability of fracture similar or above that conferred by having had a prior fracture before, using the FRATS calculator. You know, this goes from something like 135 million globally now to over 300 million in 2040. And the relative increase is greatest in lower middle income countries, as you can see here. So that distribution of osteoporosis and osteoporotic fractures is likely to change over the coming decades, to move away from Europe to and the US and Australia to low middle income countries. And that's certainly an issue that we need to think about globally, and is certainly key to our thinking at IOF as well. But of course, we have this massive burden, and we know how to define osteoporosis, we know how to assess it, we have fantastic treatments. But the really sad thing is that we don't actually treat as many people as we should do. So again, this assessment of osteoporosis care and treatment in Europe, we see that on average around 71% of individuals who are at high fracture risk, this is women here, are not actually treated. And clearly not everybody should be treated because there'll be contraindications, but definitely more than 29% should be treated. And this pattern of under-treatment, both in terms of primary and secondary prevention, has been demonstrated in the UK, in Europe, in the US and elsewhere. And actually rates are declining in many areas. So we have this urgent and pressing need to address this care gap in osteoporosis. And this was something that we described in the 2016 World Osteoporosis Day report from the International Osteoporosis Foundation, identifying gaps across case finding and management, public awareness, government and health system issues. And it's the focus of the work that we lead through the UK Royal Osteoporosis Society Bone Research Academy in the 3 working groups moving forward to really address these gaps. So how do we take this closing the gap forward? And this is where we'll start to talk about identifying patients and treating them and assessing them and treating them appropriately. So of course, once one has had a fracture, one needs to be identified and assessed and treated, and that's the simplest way of identifying somebody at high risk of fracture. And the International Osteoporosis Foundation Capture the Fracture Programme, launched serves as a global flagship endeavour to facilitate the implementation of FLS worldwide to prevent secondary fractures. And this programme has benefits, and not least the ability to gain support to either implement an FLS in the first place, but to raise the quality of an FLS that exists, to provide benchmarking, support, webinars, mentorship. And to date we have 659 FLS from 46 countries across 6 continents, and really a fantastic range of services taking part and raising the quality internationally. And of course this links as part of the global call to action, which was announced by ASBMR, which is focusing particularly on secondary fracture prevention, and sort of brings the American perspective to the international movement represented by Capture the Fracture. And I think it's so important here that we work together globally, all of the continents, to address these issues. And I think this is really an area that is bringing the societies together to address this urgent priority. So clearly somebody's had a fracture, that's one route of identification. But what about if people haven't had a fracture yet? And here it's about assessing risk. So we want to know whether somebody's at high enough risk that we think that they should be treated with an anti-exorptive or another treatment for osteoporosis, essentially. And that process we term primary prevention. Now, of course, you'll be familiar with the concept of osteoporosis defined by bone mineral density, and the reference standard now from the IOF and the WHO is at the femoral neck. And if you look at BMD in the population, you have this normal distribution, and you see that defining osteoporosis as being a T-square or below, we only identify a very small percentage of the population as having the condition. Now that's fine. We don't want to be defining the whole population as having a condition. But the problem is that if you look at the numbers of fractures rather than the rate of fractures, because in the number of fractures is the grey bars here, because the population with a bone mineral density that's normal or in the osteopenic range is so much larger than the population that has a BMD minus 2.5 or below. Although the fracture rate in the low BMD population is much higher, the total number of fractures is much higher in the population with normal or normal to low BMD. Excuse me a second. So, what we need to do is to identify these people who don't have particularly low BMD and have a lower individual risk of fracturing, but fracture nonetheless provide a lot of the fractures that happen. So the idea of FRAX and other fracture risk calculators was to try to individualise fracture risk assessment, such that one can get a handle on people who might not have such low BMD but end up going on to fracture anyway, so that we identify more people who would fracture than we would otherwise. And the idea of FRAX was to use simple, easily acquired clinical risk factors. And so we have things like low body mass index, previous fragility fracture, parental history of hip fracture, corticosteroid treatment, current smoking, high alcohol intake, rheumatoid arthritis, and a variety of other secondary causes of osteoporosis, plus age and gender, and importantly, the ability to plug in bone mineral density. And the idea of using this very simple approach was such that this would be usable easily in primary care. And if the risk factor was not available in the record, it could easily be asked of the patient. The risk factors were therefore selected on that sort of basis of simplicity, but also on the basis that they're intuitively linked to fracture, and also that they are at least partly independent of bone mineral density. And also, I think importantly, that the risk that they tell you about is at least in part reversible through treatment for osteoporosis. Now, that's not the same thing as reversing the risk factor. Clearly, you can't reverse somebody's age, whatever people might like to think. But you can, if you select on the basis of age, or on low BMD, or on glucocorticoid treatment, for example, we know that treatment will help. And so that was one of the bases for the selection. And the idea of FRAX is that using these risk factors, you generate a risk of fracture over 10 years, you generate a risk of death over 10 years. They're brought together to generate a risk of fracture, a probability of fracture over the 10-year period, accounting for the competing risk of death. And if somebody is particularly elderly and has an expected lifespan that's less than 10 years, then effectively what your FRAX probability tells you is your probability of fracture over your remaining lifespan, if that's shorter than 10 years. So contrary to the thoughts that some people have put forward, actually FRAX is very appropriate at that older age, even though it starts off with a 10-year time frame. And what you get is a probability of major osteoporotic fracture, so hip, clinical vertebral, proximal humerus, distal forearm, or hip fracture. And you'll be familiar with the algorithm and the web page, the UK. And because we know that fracture rates vary by country, the FRAX algorithm is calibrated to the risk of death and the risk of fracture in each individual country, or within some countries, different ethnic groups within that country where fracture rates are very different between them. And I think so, and FRAX as an algorithm is now central to 120 or so guidelines internationally, and you can see that if you look at the baseline sort of background 10-year major osteoporotic fracture probability across different countries and different ethnicities within countries, you can see there's quite a lot of difference. And so if you had an absolute fracture probability threshold, as is the case for osteopenic patients in America, at 20% for major osteoporotic fracture, you could see that, say, in China, you'd identify very few people that would be over that threshold. And so one of the key issues in terms of how you decide who should be treated, you've identified your patient on the basis of a risk factor, you've assessed their probability through FRAX, you may have measured their BMD and plugged that in. So you've got an idea of their probability. But if you look at the example here, it's 27% probability, a low probability, an average probability. I think probably most people would say that 27% was reasonably high, but if it was 20% or 15%, is that high or low? Do I treat at that basis? And so we need some sort of threshold to guide us as to whether we should treat or not. Now, in some situations, for example, the US guidance, there's either BMD or fixed threshold to decide treatment. And 39 of the guidelines use 20% as the threshold, but mainly on the basis that that's what the US has done, not on the basis that it's appropriate for their country. In Europe, in the European guidance, and in the UK, we use a threshold that is age dependent, and so it's set as the probability of fracture equivalent to that conferred by having had a prior fracture. For somebody at the same age with an average BMI and no other risk factors. And so that of course gives you an age-dependent threshold, and it still identifies a large proportion of older patients and younger patients. But it enables you to sort of calibrate to the age of the patient. And FRAX is now available as a model in 64 nations, covering 80% of the world population, 34 languages, and has over 3 million visits a year. And was developed on the basis of a long program of systematic reviews in 10 discovery and 11 validation cohorts across tens of thousands of person years, and offers the best validated approach to risk assessment globally, and well calibrated to individual countries. So in the UK, this is the sort of approach we use, and there's a whole variety of different approaches, but this sort of encapsulates the European guidance, and this basically just starts off with a clinical risk factor, and then we assess fracture probability using FRAX, and you can, on the FRAX website, if I show here, there, on the UK page, there's a view NOG guidance, and the National Osteoporosis Guideline Group is our national guidance, and we click on that, and then you get this nomogram with a little cross on it for your patient. And that tells us whether, on the basis of clinical risk factors, the patient is low risk, intermediate risk, or high risk. You'll notice that on the UK nomogram, there's a levelling off at age 70. That was for reasons of equity at older ages, because of the premise of treating if somebody had a probability greater than that of somebody with a prior fracture. We can talk about more about that later if need be. But then if you're in this intermediate zone, then that suggests measure bone mineral density, which then you do if you've got access to it, and then you can plug that in, and then a second nomogram which comes up on the NOG site, which is either green or red, and that suggests low or high. But of course, if you don't have bone mineral density, then FRAX can just be used on the basis of clinical risk factors only, to look at low or high above this dotted line, which is the intervention threshold. So where are we going with this sort of idea? Well, at the moment, and historically, whatever your threshold is, we've really looked at this as a sort of binary treat or don't treat. We haven't really differentiated too much about exactly what to treat with. Now, The idea that arises with the advent of anabolic therapies in particular, which we know head-to-head there's evidence for greater efficacy against anti-resorptives and faster onset of action. That leads us to the question of whether it might be sensible for those very high-risk individuals to target the specific treatment rather than just decide treat or not to treat. And in an IOF SKO workshop last year, we looked at this and developed revised thresholds in this model here, which suggested that if you're in that definitely in the red zone, then we'll call that very high risk. If you're in this amber zone, which was the sort of intermediate zone where you suggest that a BMD measurement is needed, and you're above the intervention line, then that suggests that if you're above that after you've had your BMD measured, that's high risk. And if you're here but then you have a BMD and you move up, that's very high risk. If you're there ready, you stay very high risk. Or you can be low risk after BMD or low risk. And this gives us a sort of extra degree of nuance in terms of how we can assess treatment and assess risk and look at treatment. And it gives us this way of looking at whether somebody ends up being low risk or high risk or very high risk. And the way we thought about it was that if you're low risk, then clearly there are things you want to do, such as optimize calcium vitamin D status, think about appropriate exercise, reassurance, lifestyle advice, for example, just stop smoking, moderate alcohol at most. But then in postmenopausal women, for example, you might want to consider postmenopausal hormone therapy, or menopausal hormone therapy as it's now called, or for older women perhaps selective estrogen receptor modulators in a sort of carefully risk-balanced way. The high risk, we might want to optimize calcium vitamin D status. You would want to look at appropriate exercise and falls prevention, and then consider probably an anti-resorptive in this setting. And that most usually would be an oral bisphosphonate. There might be a parenteral bisphosphonate or anti-resorptive such as denosumab. But in that very high risk category, where somebody is on clinical risk factors alone or moved up there with BMD, is well and truly in the high risk zone. We call that very high risk. And there, of course, you need the optimized calcium vitamin D, the appropriate exercise and falls prevention. But there you might think about anabolic agent as first line. Now this is something of a departure from the way many of us have used anabolic agents to date. And of course it may be that this is not something that it's very easy to do given your local guidance. And certainly in the UK at the moment, NICE guidance doesn't really favour anabolic first. But of course, the NICE guidance was changed several years after the National Osteoporosis Guideline Group guidance came to really adopt the NOG approach. So I kind of think if we want to advance the field, we have to push for these things which we think are going to do our patients good. And it seems very logically reasonable to think that an anabolic first, so building up bone density actively, and then consolidating that, so a sort of remission and then maintenance type approach, as we now do in rheumatoid arthritis, for example, with inflammation, might be a better way of doing it. And if you look at the approach to the percentage of the population stratified, this is a typical sort of pattern you might guess. This was in a UK simulated cohort. So you see overall the numbers at high or very high risk increase with age, as you'd expect. And depends upon exactly how you do the curves and where you make the cut-offs. And in the latest iteration of the National Osteoporosis Guideline Group guidance, we've adopted a slightly different picture. And so you get slightly different proportions, but that's the aspiration for taking us forward. So just briefly, in the next 5 or 10 minutes, one concept that is in much discussion at the moment is that of imminent fracture risk. And this concept that you might measure for 2 years to judge whether somebody, for example, after fracture might warrant treatment. And of course, there's many different ways, there's several different published approaches to do this. I think the issue with that is that it doesn't, that approach doesn't always compare 2 years with 10 years. And effectively what you're doing is developing a model that gives you fracture risk over a couple of years, which is fine and can be very useful. But what you can't then do is say that they're different determinants to those of longer term. And actually, if you're high risk in 2 years, over the next 2 years, you're going to be high risk over the next 10 years, indeed over your lifetime. But there are some risk factors which have a short-term particular increase in fracture risk associated with them. One of those is an incident fracture. And in the Reykjavik cohort, we saw that the incidence of a second fracture was very raised immediately after first, went down over the first few years, but then didn't plateau, but then gradually rose with age, as you'd expect, but was always higher than the risk of a first fracture in the whole population. So risk of a subsequent fracture after a first fracture is particularly raised in the first couple of years, but and wanes over that time's raised going forward. And what we find is that actually the magnitude of that for increased fracture risk transiently influences your 10-year fracs probability. And so what we have done is develop multipliers for fracs probability based on recency of fracture. So for example here, fracture at a particular site in the last 2 years compared with the standard fracs input, which is just a prior fracture of any site at any time, to see what effect that has on your fracture probability. We've done this for women and men, and you find that here we have the, for example, humerus. We can see there's a multiplier of, say, at the age of 60, 1.54 times your major osteoporotic fracture probability over 10 years. And the advantage of using 10-year probability is that we already have guidelines based on 10-year probability. And so this approach can be plugged straight into existing guidelines to decide a way forward. It's something that we're incorporating into the UK NOG guidance. At the moment, it's a bit cumbersome because this is a manual process, but we're imminently, if you'll excuse the reference, developing a modified fracs input, which allows you to take account of recency and fracture site, such that these can be automatically considered in the fracs algorithm, which will greatly simplify the approach. And just to add that I think when one looks over that sort of 2-year time frame, the different approaches to 2-year risk, including fracs, if you do the appropriate calculations to get an equivalent fracs probability over 2 years, incorporating recency, seem to give roughly the same sorts of answers, which is generally reassuring. So, to my mind, it's as much about ease of use, ease of implementation, and linkage to national guidance as to the exact approach employed. So, how do we implement this in clinical practice, and does it work? Well, we have undertaken a large randomised trial across 7 centres in the UK with about 12,000 older women assessed in primary care. And these women were assessed in terms of fracture probability, plus or minus BMD, for those intermediate and high risk, and then with suggestions for treatment fed back to the GP. And so half of the half of the group were randomised to screening and half of them to usual care. So it was basically luck whether they ended up with an osteoporosis risk assessment in the usual care group. And what we find is that across the 5 years of follow-up, there's a 28% reduction in the incidence of hip fracture. And bear in mind, it was hip fracture probability upon which intervention was predicated. There was no effect on osteoporotic fracture or major osteoporotic fracture, but it seems pretty consistent with the methodology. There was an effect on hip fracture, and we know from subsequent analyses that both the proportion of patients treated and the adherence to medication was higher in the high-risk intervention group, and also that it was the individuals with the highest baseline risk by FRAX in the screening group who had the biggest benefit from intervention, which again is consistent because they're the ones who got treatment. And we know that it is health economically sensible. In fact, it's actually cost saving. So this approach appears to be clinically effective and cost effective. And there have been a couple of other similar trials, one in the Netherlands and one in Denmark, which when meta-analysed together give a similar sort of picture. Here, a bit of a signal for major osteoporotic fracture, and certainly for hip fracture. And one of the activities that we're leading through the Committee of Scientific Advisors is to look at a position paper on screening, which is led by Eugene McCluskey and is in final stages of preparation, that will really set out the imperative to adopt at least a systematic case-finding approach, which you might view as screening. And in the UK, again through Eugene's leadership, as part of the Royal Osteoporosis Society, Osteoporosis Bone Research Academy, we are actively exploring, investigating the means with which such an activity might be undertaken. For example, the routine sort of flagging up of high risk in primary care systems, and linkage with automatic assessment of vertebral fractures, for example, from routine imaging. Indeed, we just obtained a large grant led by Catherine Gervais and Ken Poole to undertake that NHSX. So there's a lot going on in this space, and I think if we could get this cracked to actually really efficiently identify people at high fracture risk, then we'll be going a massive way to improving care in osteoporosis. So just very briefly, because I think one of the things to talk about was long-term treatment, and I won't say much about this. We're all aware of the concern over rare side effects of anti-resorptives, and some of the misinformation around these outcomes has been responsible for really the reduction in care, both not just amongst patients' attitudes, but amongst physicians as well. But these are very rare outcomes, which of course we need to be aware of and mitigate, but the risk is clearly overplayed in many areas, and it's very readily apparent that there are many patients out there who just suffer because they are so worried about incredibly rare side effects, but ignore the fact that they have a 30% or 40% or 50% risk of major osteoporotic fracture. And that's a really unfortunate state of affairs. So our approach to longer term treatment is more along the lines that if you're at high risk of fracture, you're looking at a lifetime consideration of treatment. Now that doesn't necessarily mean you will be constantly treated for a lifetime, but it means that the expectation is that you will be under consideration for treatment. You might have a drug, might have a period off medication, but the expectation is you'll go back onto it. And that contrasts sharply with what the perception had been in some quarters, I think not particularly helped by some recent UK multimorbidity guidance, that you might just have a course of a bisphosphonate for 3 years, say. And I think if you get nothing else from this, just view osteoporosis treatment as a lifelong thing, which there may be periods of treatment, but the imperative is to consider treatment lifelong. Because it's just awful when I see somebody in clinic who's had a drug holiday 10 years ago, never got put back on, and then comes along with 3 vertebral fractures, and that's just not something that's acceptable. So we've taken a sort of pragmatic approach to the evidence, and actually the evidence base for bisphosphonates is not better than it is for most chronic treatments, in that we actually have some evidence, because who stops a statin and then monitors the results? It's not something that's done in other areas. And the idea is, these are the older guidance, we're just revising them at the moment. So the idea is that you'd have a sort of initial oral bisphosphonate treatment for 5 years, then review, IV Zol for 3 years, and then if you're at low risk, then you might have a break for treatment and then reassess. If you're at high risk, for example, low BMD, intercurrent fracture on steroids, then you might go for another 5 years and reassess, or another 3 years for IV. Clearly something like denosumab, where there's a problem if you stop it, may well be is a different kettle of fish and needs individual assessment. I quite often use that in older patients as a lifelong therapy, and we can talk more about these details. And just reassuringly, data from Bo Abrahamson has suggested that long term, even after 10 years, the numbers of fractures saved is still greater than any risk of subtrochanteric fractures. So to finish, osteoporosis-related fractures have a huge burden. They're common, they're associated with huge morbidity, mortality, and economic impact. So impact both at the level of the individual, of healthcare systems and societies as a whole. We have really good ways of assessing fracture risk. FRAX is central to 120 guidelines internationally. We're looking at ways to personalise the specific therapy by fracture risk. And there's an absolute global imperative, both in primary and secondary fracture prevention, that we need to close the care gap to ensure that everybody at high fracture risk is appropriately identified, assessed and treated. So with that, I thank very much the IOF and IOF LATAM for inviting me to give this presentation, all of my co-authors and the FRAX team and our funders. So thank you very much, and I look forward to the discussion.
Great. Thank you so much, Professor Harvey. This was really a real treat for all of us. And we have a lot of time now to be able to discuss subjects and some points they upon.
So I will encourage everyone to send your questions. This is like a unique opportunity. You can send your questions in Portuguese, in Spanish, or in English, and even you can open your microphone and pose your question. This is an informal setting, and we're here to have a discussion as productive as possible. We already have some questions. The first question is posed by Claudia Santos, who says, she compliments you for your talk, and she mentions about the difficulty of analyzing patients that have hip replacement. So they had a hip fracture, the hip was replaced, we don't have that densitometry site anymore, and she asks about when to introduce treatment in these people. And I would go a bit further and ask you about the femoral neck. I know the UK is very adamant about using the femoral neck only for diagnosis of osteoporosis. And if you could talk to us a little bit about what's the risks of using other sites, in some cases such as glucocorticoid-induced osteoporosis. It's a common observation that they will lose more in the lumbar spine than the femoral neck, so we might be missing something around that.
Okay, yeah, so several points there. So I mean, I think obviously with hip placements, it depends upon whether it's unilateral or bilateral, but assuming that it's bilateral and you just can't use the hip, of course you've still got the lumbar spine, but of course, if you've had a hip placement because of osteoarthritis, for example, if you've osteoarthritic change at the spine and that may be falsely elevated, you could use the distal radius. I mean, in my experience, it doesn't seem to be that helpful a site. It often seems to be quite different to other sites. There's this sort of theory that it's useful in hyperparathyroidism, but I'm not sure how rigorously that's been proven. I think you just have to, I mean, you can use obviously clinical risk factor assessment using FRAX, and I think you need to be guided by certainly if there's a prior fracture, you can sort of, in many individuals, you can form a judgment based on the FRAX clinical risk factors, and particular thing is there a prior fracture? Are there vertebral fractures? Which is an absolute, so if your DXA instrument can do vertebral fracture assessment, that's often very helpful. And if they're on high dose glucocorticoids, for example, well, that's a clear risk factor. So I think that's, I think medicine is an art as well as a science. And I think more and more we're under pressure to follow protocols and follow rules. But life isn't just, it just isn't like that. There's shades of grey in medicine, and I think ultimately it comes down to just clinical judgment. And the important thing about FRAX is that it is stressed all the way through with FRAX that it does not replace clinical judgment. So you have to remain a competent physician looking after your patient, and that's absolutely vital. In terms of the standardisation, I mean, I think the femoral neck, the idea of the femoral neck being the reference standard is purely that it's a reference standard. And we published a paper, gosh, I don't know, maybe 10 years ago now, that just said it would be a really useful thing if every study that had densitometry in it reported BMD at the femoral neck, so that there's an international standard on which to compare. There's pros and cons, so I think it's more precise at the femoral neck, but it's easier to measure. You've got more tissue at the hip, so there's pros and cons in terms of what you want it for. I mean, our densitometer, our reports show both. I think you just need to know what you're inputting into FRAX and look carefully at the menu options and make sure you don't stick in total hip when you've clicked femoral neck, and that sort of thing. So I don't think it really matters that much day to day. It's more there as a means of international standardisation for research ultimately.
Brilliant. Perfect. So the following question that we had in the questions and in the chat, there was something touching that too, is how reliable is it to use FRAX in a country where it's not calibrated? And there was a question also in the chat, like if you have a statistical reference in Latin America, and I think it touches upon that, like countries where FRAX has not been validated in terms of that.
Yeah, I think one has to be careful about that. And I mean, it may be that you can use a surrogate model, and for some countries that over the years, surrogate models have been used based on a country with what appears to be intuitively a similar fracture and death rate. Now, there's a lot of risk with that because you can be caught out, and so I think it's. You can look for a surrogate population and try and base your decisions on that. Of course, it comes with the caveat that it might not be right. If there is no model in your country, there's not a lot more one could do. But I think the absolute thing one has to be clear about is that there are massive differences in background fracture probabilities between countries. And if you use, say, the Swedish model in if you use the Chinese model in Sweden, you'd end up with everybody having a really low fracture risk, and actually they've actually got a really high one, and sort of vice versa. So you've got to try and use the appropriate model. If there's not a model in that country, the approach is either to see whether it's possible to develop a surrogate model based on a neighbouring country or similar population, and that's been done in many areas, and we're open to chatting about that, contacting me or Eugene or Prof. Canis to do that is possible. Or do a big study and map the epidemiology, and that, because usually you can get death rates from government figures, but it's getting the risk of hip. If you get the age and sex stratified incidence of hip fracture, then that's enough to sort it out.
Brilliant. We have more questions from the chat. I'm going to make a question now. I was really impressed by your chart that showed the adjustment due to recency of fractures, right, and how it changes. And it struck me how it affects more younger people than older people. So for the 90 years old, it actually got below what before, right?
Hip fracture, yes.
So
Absolutely.
why is that? Is it had to do with the life expectancy, or?
There's a number of things, and I think at the old, because it's probability, it brings together risk of fracture and risk of death. And a prior fracture at many sites, for hip fracture, it has at older ages, it has a massive effect on risk of death. And of course, the earlier you die, the less time at risk you've got of having a fracture. So paradoxically, it can actually potentially reduce your risk of having a fracture when you're 90, because you don't live long enough to have a fracture, which is not the best way to prevent a further fracture. So there's this effect of competing mortality. At younger age, of course, you don't really have that competing mortality effect. But what you do find is that if you, as with many risk factors, if you're young and you've got a risk factor, then you're unusual. Because you're in because what we're doing there is comparing the risk following a specific fracture within the last 2 years compared with any fracture any time. And if you're young and you've had one in the last couple of years at a specific site, because so few other people in the background population are in that situation, it's an even bigger effect than just having had any fracture at any time in the past. So it's like all of pretty much every risk factor we look at, in relative terms, having that risk factor has a bigger relative effect on your risk than not having it at younger ages. But of course, the absolute fracture risk will still be very low at that young age.
Perfect. Because normally we have this feeling, say, like a postmenopausal woman that's not so old, she has a forearm fracture, and we tend to consider it subjectively as not as risky as a forearm fracture in someone who's 80 years old, but it has to do with what you're saying, right? Because that will multiply the risk, but still numerically will be a not so great risk.
And I think the thing to bear in mind there is that for the 50-year-old, the starting point of risk will be here, and it might go up to here. But then for the 80-year-old, the starting point of risk is here, and it might only go up a little bit, but it's still way higher than for the 50-year-old. So you've got to be clear about relative versus absolute risk, and there's a lot of nuance in the figures, but basically, higher risk at older ages generally.
Brilliant. And you mentioned that this adjustment will be available soon for us.
That's the idea, yes. So we've got a sort of beta site developed, and I'm not quite sure when exactly that will go live, but it's not far off, and that will allow you to select time window in the last couple of years and fracture site, and just give you a modifier to modify your fracture probability, which will greatly simplify the process.
Perfect. We have a question that was sent via the chat asking you to comment about superiority amongst bisphosphonates in terms of performance.
Yeah, I mean, I think there's not a huge amount of head-to-head data for bisphosphonates specifically, but I think what I do feel these days is that the issues of compliance with oral bisphosphonates, it's only a few % of the oral dose that's absorbed, and I think in somebody who's very who's high risk of fracture, and I definitely want to know that they're getting treated. Particularly if there's vertebral fractures there. More and more, my inclination is to start with basically zoledronate as the intravenous version, because I know that it's in the system. I know they're protected. They don't have, if they would have just flushed the tablets down the loo or put them in a cupboard or something and not taken them, that's irrelevant because they've had the infusion. And I think, and in the older population, going straight on to denosumab, but just saying, well, you know, you're 75, just go on to denosumab lifelong. It greatly simplifies things and means that you know that it's getting into the system. And so, you know, that would be my inclination. And you know, the magnitude of the risk reduction seems a bit greater with IV than IVs old and bisphosphonates, but you know, there's not a huge amount of head-to-head. So, but that's my feeling. And the more I see, the more cautious I get about using. I mean, all bisphosphonates are fine on that sort of moderate to high risk, but definite high risk, and particularly privertebral fractures. I feel more comfortable if I know that I've got something into the parenteral.
Perfect. We have a question on the questions and answers now about is it useful to use fracs in rheumatoid arthritis population?
Yes, so there's a box to tick for rheumatoid arthritis, and that gives you information over and above BMD. The secondary causes option is only modifies the fracture probability if BMD is not input. But rheumatoid arthritis is separate. Absolutely, I mean, rheumatoid arthritis patients have greater risk of fracture. They're on all sorts of medications. I mean, it's really steroids that increase the fracture risk, and hopefully, you know, they won't be on as many as they would have been in years past, but they're still needed a lot. But even so, there's risk of fracture. So absolutely, use fracs in rheumatoid arthritis.
Great. So we're touching the end. We have 5 minutes more by my calculation. We have several questions too. I'm going to pose a question now by Professor Patricia Clark. In the UK, the risk of fracture and risk of death after 70 in probability, is it similar? And then to treat equally after 70 is the appropriate thing to do?
Yes. I don't quite understand the question, but to be honest, I'm not sure about the relative magnitude of the risk of fracture, the risk of death at particular ages. But I think where you, maybe Patricia, and it's great to hear from you, Patricia, thank you. If it's about the flattening off of the NOG threshold at age 70 years, which it might be, the reason for that is the idea is that the previous threshold went up with age across all ages, but and that was based on the probability equivalent to having had a prior fracture. The problem is that that's the average probability, and so somebody who's had a prior fracture actually might have a probability above that or below that. Somebody who's not had a prior fracture could actually have the same probability as somebody who has had a prior fracture in reality, but still be under the line. So in order to balance that up, we levelled off at age 70, and it makes better use of DXA. It's a more efficient system, and it provides equity to those older patients, and so that was the reason for doing that. It takes a bit to get your head around, but that was the underlying philosophy. So I hope that was the answer to the question, but
I think it was.
Respond afterwards. Yeah.
I think it was. She thanked you, so good. All right, so we have a question who's based on a clinical case. So it's a woman, 55 years old. She's a sportist. I don't quite know how to say that in English. Well, she's very active and she does a lot of sports. And she has had 3 previous fractures: forearm, tibia, and the foot. All 3 of them without much of an impact, so they look like fragility fractures. She's intolerant to oral bisphonates. In this particular case, would you start with a bone-forming agent, or would you go towards IV or maybe denosumab, anti-resorptive, non-oral, or bone-forming?
Yeah, I don't know. I think it's very difficult to comment on specific clinical things when you haven't got the patient in front of you. But I think, with very sporty people, of course, you need to be aware of the issue of stress fractures, particularly in the feet. Tibia is sort of variably low impact type of event. I mean, are they stress fractures? Are they true osteoporotic fractures? Obviously, you need to know what the BMD is doing. Is there any what's the vitamin D? Is any osteomalacia? Is it all indoor sport or is it outdoor sport? So there's a whole range of things one might need to consider. But I think if the BMD were very low and it needed treating and there was access to an anabolic, then I'd probably want to go for an anabolic because it's a fantastic opportunity to build up the bone before it gets, before you lose more. But that's so dependent from the individual clinical scenario and what you're allowed to do in any particular country. I wouldn't be able to do that in the UK, for example.
All right. I said that Monica has opened her camera, so I'm assuming I'm in the final minutes of. I just want to make one very last question. I've asked you this before, Nick, and I hope you don't get upset with me asking again. Okay. What about diabetes in FRAX? Any news about how, if soon is coming an adjustment, if it's going to be post-calculation, pre-calculation, what's happening there?
Yes, so we've amassed vast numbers of patients in various cohorts for the FRAX version 2. So we're actively looking at various potential risk factors, and certainly type 2 diabetes is something that we're actively looking at. It depends whether it finally makes the cut as part of the algorithm will depend upon what data are there, what we find. Is it sort of rigorous enough? For something that isn't quite rigorous enough to be part of the algorithm, it might be that there's scope to do what we did with TBS and what we're doing with prior timing of prior fracture, which is to have a sort of, as Eugene calls it, a post-translational modification, where you just a multiplier to FRAX that can be implemented afterwards. So it's absolutely on the agenda, and it's going to take a while to develop the second model.
All right. Thank you very much for your presentation, Dr. Harvey, which was amazing as always. Thank you very much for your disposition for all these questions. I think we didn't complete all the questions, but I think we did a lot, and it was a very useful discussion. And I'll pass it over now to Monica to close the session with my thanks to Monica and to you.
Well, thank you, Bruno.
Thank you, both of you. Thank you, Professor Harvey. Thank you. The presentation was really fantastic, and I hope the audience enjoy it as much as we did. And thank you, Professor Ferraz, for coordinating such an interesting debate. There were a lot of questions, so I think that people really enjoyed the presentation, and it was really interesting. Thank you to the audience for participating. That makes the session a lot more interesting for everyone. And we look forward to seeing you all again at our last session of the year. That would be on November the 2nd, when we will talk about rehabilitation in osteoporosis, the effect on quality of life and fracture risk, and that will be by Professor Olivier Bruyère. So stay tuned, and thank you all very much for your participation. Bye-bye now.
Thank you.
Thank you. Bye-bye.
Thank you, and bye all.
Bye.
Muchas gracias a todos los que se conectaron. Les recordamos que van a tener la grabación disponible en el canal de YouTube de la IOF. Muchas gracias.